therapy. What is that?
Sir, this entity has been discussed because more amount of oxygen has been given to the patients during mechanical ventilation, and its harmful effects is more than its beneficial effects, and that is why this entity has to be understood a little bit. Uh,
Very good.
Oxygen is a drug, and it has a very narrow therapeutic efficacy and safety in sepsis. So, uh, the liberal oxygen therapy induces hyperoxemia in most patients and decreases their survival. High oxygen levels in the central venous blood increases the mortality in patients, especially who are facing sepsis in ICU patients. And high oxygen supplementations of more than FiO2 of 65% and hypoxemia of PaO2 of less than 7 kilopascals can increase the in-hospital mortality. The short-term hyperoxia of less than 7 to 10 minutes can cause atelectasis. So, providing normoxemia may reduce the negative effects of hyperoxemia in sepsis. So, in sepsis, this high oxygen can be used for treating bacteremia, where the excessive oxygen binds with the RBCs and something called as oxycytosis happens, and this oxygen is released from RBC and helps in the degradation of the bacteria. But however, we tend to give more than what is actually required, leading to the formation of reactive oxygen species, and activation of platelets happens, and the oxidative stress to the plasma proteins happens, and plasma protein, not only plasma proteins but also the lipids, amino acids, hormones, vitamins, and all other biologically active agents gets oxidized and finally ending up in DIC. So the harmful effects of oxygen is more when we tend to give more than what is
More.
actually required for the patient, and that is why we need to concentrate on how to administer oxygen uh, and how to bring down the FiO2 as early as possible. So
What is the various concentrations that you can safely use for various hours?
there
How
is
many
actually
hours you can give 100%? Hmm?
usually what we do is the usual oxygen therapy is there are three entities called upper limit of SpO2, the target range, and the lower limit of SpO2. In the upper limit of SpO2, there is no actual protocol defined for the upper limit of SpO2, and there is also we also don't set any upper SpO2 limit alarms also in the monitor. The target SpO2 is something which is set by the target range is set by the treating physician, and any SpO2 greater than the lower limit is acceptable, and the use of an FiO2 of less than 0.3% is discouraged in the usual oxygen therapy. And lower limit of SpO2, the third thing is how to set the lower limit of SpO2. This is also set by the treating physician. If at all the treating physician doesn't set a lower limit of SpO2, then the target of more than 91% is set, and we administer the FiO2 accordingly. Uh, Now coming to the conservative oxygen therapy, here again there are three entities where there is something called too high and just right, which is the target range, and too low. Too high is we set, and an SpO2 of more than 97 is too high for us. Any use of fractional oxygen concentration of more than 0.21 is considered as too high according to this therapy, and we have to reduce the FiO2 by 0.10 at intervals of no greater than 5 minutes until an SpO2 is less than 97%. Now coming to the target range, the use of lowest FiO2 possible to achieve an acceptable SpO2 has to be set and achieved. And if the FiO2 is more than 0.21, it should be decreased by at least 0.05 at intervals of 30 minutes or less until an FiO2 of 0.21 is achieved. So if the SpO2 falls below the target range, we have to bring back the FiO2 to the previous uh, thing which was already set. Now coming to the too low entity in the conservative oxygen therapy, where the SpO2 lower limit is set by the treating physician. If at all it is not set, then we have to set an SpO2 of more than 91%. Uh, And if the SpO2 falls below the target range during the decrease in FiO2 titration, immediately return the previous FiO2 to the target SpO2. We have to return back to the previous FiO2 levels. So this is the protocol,
You
sir,
must
for
always correlate your SpO2 value with the oxygen FiO2 so that you can give the lowest FiO2 possible to maintain the maximum SiO2 or CO2. Okay, that is the idea. So as a
yes,
general blanket rule, they say that 100% oxygen can be given maximum for 12 hours, 80% for 24 hours, 60% for 36 hours, and 50% for any number of hours. So this is the blanket rule. 12 hours for 100%, 24 hours for 80%, 36 hours for 60%, and 50% is safe for any number of hours. So whenever any patient is started off with a higher FiO2, you must try to achieve not more than 50% at the earliest so that we can avoid all the problems of oxygen toxicity. Okay, right. So that is what we can. So more than enough for this question. I think there's another half of this, another part of this question. Happy hypoxia, isn't it?
yes, sir. Yes, sir.
Complete that also. Then I will share my PPT and finish the class.
Yes, sir. Okay, sir. This happy hypoxemia is an entity which was come into discussion after the COVID-19 outbreak. It is usually seen because the severity of hypoxemia and the relatively mild respiratory discomfort reported in the patient was difficult for the physician to treat and predict how he progresses in the treatment. So that is why this has to be understood a little bit. So happy or silent hypoxemia is not exclusively seen in COVID-19 patients, but it is also seen in patients with atelectasis, intrapulmonary shunts, and right to left intracardiac shunts. So we need to know the main afferent inputs of the respiratory center. The respiratory center is present in the pons and the medulla, which we all know. But the main inputs for the respiratory center include the central chemoreceptors, the peripheral chemosensors, the stretch receptors, the J receptors present in the lungs, the higher brain center, which is the voluntary control of breathing, the pain and the emotional stimuli acting via the hypothalamus, and the stretch receptors present in the muscle. So the changes in the partial gas pressure of the dissolved carbon dioxide in the blood, which is the PaCO2, seems the most important component in shifting the pH, which causes the shifts in the pH at the level of both the peripheral and the central chemosensors. So when the PaO2 drops below 40 millimeter of mercury, usually dyspnea occurs. But of note, in normal response to hypoxemia, it is a rise in the minute ventilation, which is achieved primarily by increasing the tidal volume and the respiratory rate. So increased respiratory rate, that is tachypnea, and tidal volume, which is hyperapnea and not dyspnea, are therefore the most important clinical signs of impending hypoxemic respiratory failure. So what actually happens in happy hypoxemia is the oxygen hemoglobin dissociation curve, which is sigmoid shaped usually. The sigmoid shaped oxygen dissociation ODC curve shifts to the left due to induced respiratory alkalosis, where there is a drop in PaCO2 because of hypoxemia driven tachypnea and hyperapnea. During hypocapnic periods, the affinity of the hemoglobin for oxygen and thus oxygen saturation increases for a given degree of PaO2, and explaining why the SpO2 is well preserved in the face of profoundly low PaO2. Now, there is also a biological explanation, which is called as a forward hypothesis, where there is a viral interaction with the heme group of the hemoglobin. The heme serum levels are increasing in COVID-19 patients, along with the harmful effects of the iron ions, causing inflammation and cell death, which is called as the ferroptosis. This leads to the production of large amount of serum ferritin to bind with these free irons in order to reduce the tissue damage, which is also a safety mechanism. Uh, the commonest causes for hypoxemia in COVID-19 is the intrapulmonary shunting, which happens, and the in presence of intravascular microthrombi, loss of lung perfusion regulation, and the impaired diffusion capacity, and preservation of lung mechanics. So as the PaO2 decreases, the commonest symptom, which is the hyperapnea and the increase in the respiratory rate, which happens during this time, we may introduce antivirals for the treatment, which helps in reducing the immunosuppression. Now, beyond once we find out that patient develops to have intrapulmonary shunting, which can be found out as edema and atelectasis through radiological scans, and the presence of intravascular microthrombi, and the loss of any lung perfusion regulation, which can be found out in the ABGs. Now we have to introduce anti-inflammatory medicines at this point of time, and also we have to go for awake prone ventilation, and we have to start off with anticoagulation along with face mask oxygen therapy, or HFNO, or whatever is non-invasive oxygen therapy. Now, once the patient start developing dyspnea, at this point of time, there is reduced lung compliance and increased dead space development, and increased consolidation and atelectasis, which has set in, and the CO2 retention happens. At this point of time, we have to go for invasive mechanical ventilation and prone ventilation, and the ECMO if at all necessary. So this is the mechanism and treatment of happy hypoxemia, sir.
Sequences of active hypoxemia. Okay, that's a nice presentation. I'll just show this conservative oxygen therapy. As you rightly said, too much of oxygen is bad. So administration of lower levels of supplemental oxygen than usual in order to tolerate a lower level of arterial oxygenation, that is partial pressure, than normal, is what is called conservative oxygen therapy. Purpose is to reduce the overall exposure to unnecessary additional oxygen that is not required for the body. So the approach to oxygen therapy has been called as permissive hypoxemia. All these days we were talking about permissive hypercapnia, especially in ARDS ventilation patients when they have increased CO2 levels. We don't try to hyperventilate and wash out that CO2 and allow that CO2 to remain up to say 60, 65 also. We never used to try to correct it. So that is called permissive hypercapnia. So here they found that excess of oxygen causes, as Lokeswar mentioned, a lot of unnecessary complications. They have said that you can allow to some extent hypoxemia, which is called the permissive hypoxemia. So hyperoxia can be associated with poor clinical outcome, and patients are especially ventilated mechanically. Uh, they have traumatic brain injury or after resuscitation from cardiac arrest, post cardiac arrest care or myocardial infarction. Nowadays, they say that you should not give too much of 100% oxygen when patient comes with acute coronary syndrome. We have to go for a lesser oxygen PaO2. In the clinical settings in which oxygen toxicity occurs is predominantly divided into two groups. One in which the patient is exposed to very high concentration for a short duration, and the second category is patient exposed to lower concentration for a longer duration. So these are the two types of patients they studied. So the two cases can result in acute and chronic oxygen toxicity respectively. So when you give very high concentration like 100% for a shorter duration also, it can produce oxygen toxicity, or lesser concentration for a longer time, that also can produce the same result. So oxygen-derived free radicals have been proposed as being the probable etiological cause for the development of oxygen toxicity. And these free radicals are generated due to mitochondrial oxidoreductive processes. also induced by function of enzymes like xanthine and urate oxidase at extramitochondrial sites from auto-oxidative reactions. So this may damage the pulmonary epithelium, inactivate the surfactant. So how oxygen toxicity affects the lung? That pathology is very important. So when you give very high concentration, they develop free oxygen-derived free radicals. These free radicals will damage the pulmonary epithelium, inactivate the surfactant, and form intraalveolar edema, interstitial thickening, fibrosis, and ultimately lead to pulmonary adductation. So oxygen toxicity simulates the development of pulmonary edema, congestion, intraalveolar hemorrhage, and pulmonary injury. So the lowest possible concentration of oxygen that alleviates tissue hypoxia is optimal in patients with ARDS and decompensated neonates who are at particular risk of retrolental hyperplasia also. So the neonates, that's why we don't want to give higher concentration in children. And so these are some of the points you can add to the conservative. And another important point I have not added there is when you give lesser percentage or concentration of oxygen, you conserve the cost effective also. So you don't have to unnecessarily cause wastage and expense to the hospital and patient. So it's cost saving also. And coming to happy hypoxemia in COVID-19, it is a disconnect between the severity of hypoxemia and the mild relative respiratory discomfort the patient experiences. So patient may be having a desaturation, but he is not agitated or looking breathless. He is having very very mild respiratory discomfort, which is that sometimes does not even complain of, but he is having a when you put the pulse oximeter, the saturation is very low. So that is why it is also called as silent hypoxemia. Our patient is happy, not complaining. So that is a colloquial term to say that this is not a very alarming situation experienced by the patient. So does it occur only in COVID patients? No, it can happen not exclusively in COVID, but also may happen in patients with atelectasis or patients who have intrapulmonary stenting or right left cardiac shunt. What is the mechanism? The initial phase of COVID-19, several mechanisms contribute to the development of arterial hypoxemia without a concomitant increase in the work of breathing. Then rapid clinical deterioration may occur. So these are the various diagrams which show the symptom of onset. Then there is a plateau phase. Then there is an intrapulmonary stenting leading to edema, cases, intravascular microthrombi, loss of lung perfusion, patient. So almost up to this stage, when all these changes happen, patient's PaO2 is slowly decreasing, but patient is not complaining. And then suddenly, after a particular stage, he becomes very severely dyspneic. There is reduced lung compliance, increased dead space, increased consolidation, CO2 retention, anxiety, fatigue, all these things happen. So this phase when the pathology is going on and the patient is not clinically looking very sick with respiratory distress, that is the phase you call it as silent hypoxemia. And so the oxygen therapy you initially start, and only after this stage, when the dyspnea becomes very, very severe and saturation drops drastically, you think of mechanical ventilation. Until then, you try to correct the whole thing by non-invasive oxygen therapy. And the initial stage is antiviral and reduced immunosuppression, then anti-inflammatory, awake-prone ventilation, anticoagulation, and then lung protective ventilation, prone ventilation, ECMO. So this is the strategy for selecting the various modalities of treatment. This is what during COVID it was intrapulmonary stenting, loss of lung perfusion, intravascular microthrombi, and impaired diffusion capacity. So these were the four causes of hypoxemia. And what are the time-based ventilator support? Of course, These are the various things that before intubation, during ventilation, after intubation, weaning phase, if the patient is requiring, all these things are available in the textbook, so you can go through all that. So that will complete the use for the questions that we selected for this week. Okay. So any doubts or any questions on that?